Hello, I'm Manoj Karmakar. In this upcoming video, Dr. Yavuz Gurkan from the Koç University Hospital in Istanbul, Turkey, is going to put forward his arguments that erector spinae plane block should be the technique of choice for unilateral pain or surgical procedures on the thorax. If you're enjoying our videos, do remember to like and share these videos. If you still haven't subscribed, do remember to subscribe so that you can get regular notifications of any future uploads. Now enjoy the upcoming video.
Okay, now I will be talking about ESPB, and I recommend that it should be the technique of choice for unilateral pain or surgical procedures for the thorax. Now, ESPB, I know we have been talking for now for hours, but I have to remind that it is a very simple technique, injecting local anesthetic just above transverse process and beneath the erector spinae muscle. And on the right side of the screen, you can see a cadaver, well, the skeleton actually, from a crocodile from Philippines. Transverse process really looks huge. So we have simply a very big target, very easy to catch. You cannot miss it, whether you use ultrasound or maybe for pain doctors, fluoroscopy, and so on. So it is a rather simple technique. But this technique, with this using this approach, we are actually very close to the spinal nerves and their dorsal and ventral rami. So this is a picture from the Anaesthetic team on the left side. You can see the spinal nerve, dorsal, and the ventral ramus. Actual erector spinae plane block, it's a route of local anesthetic injection, very close to the neural structure. So it's not like exactly TEP block or pectoral blocks. This time we are very close to the neural, central neuroaxial structures, to the epidural space, and also to the spinal nerves themselves and their rami. There's been lots of explanations thanks to all the previous speakers. It's just a short review that different anatomical studies interestingly end up with different results, but at least, or quite many of them have found that epidural spread is possible with ESPB. Paravertebral spread is possible. Ventral rami, the great majority says the local anesthetic or dye goes to the ventral rami, and everyone agrees that at least the dorsal rami will be affected by ESPB. And right from the start, with Ferrero's contribution to the literature and to regional anesthesia field, ESPB has been used for both chronic pain, neuropathic pain, and for postoperative analgesia for thoracic surgery. So actually, Ferrero introduced ESPB right from the start for thoracic surgery or pain originating from the thorax from different sides. And it includes shoulder surgery, and it's a very good alternative if for some reason you cannot perform interscalene block, and then you can do ESPB and it will provide some analgesia without affecting the diaphragmatic excursion. It is good for thoracic surgery, whether it's done video assisted or open, for rib fractures, for breast surgery, obviously, and also for cardiac surgery. Now for thoracic surgery, we have actually published several case reports, and we have conducted a few randomized controlled studies, and not all of them are published, not yet. But there are quite many papers suggesting that ESPB is good for thoracic surgery. And here ESPB has been compared to serratus plane block, and it has been shown for thoracoscopic surgery, and it has been shown to be superior to the serratus anterior plane block. Now, what about intercostal nerve? This time, ESPB has been compared to the intercostal nerve performed by the surgeon, And this is what happens in clinical reality. You may ask the surgeon that you're planning to do an ESPB for thoracic surgery, and he will say, don't worry, I will do the intercostal block. But what is the result? The result is that ESPB is superior to the intercostal nerve block, and it provides better patient satisfaction, better analgesia, and less respiratory muscle impairment. This time, ESPB has been compared to the intercostal nerve block, and you can see that this is a randomized study, and you can see that ESPB is superior to the intercostal nerve block. Now, this time, 59 patients, a large series. ESPB has been used for thoracic surgery, and the cases include minimally invasive robotic thoracoscopy, thoracotomy, rib plating, and non-operative reasons. And it has been shown that ESPB should be considered as part of ERAS and provide non-narcotic ways to control pain therapy. And it has been recommended to be clinically effective by a large group of researchers. And the only complications are catheter dislodgement problems or catheter problems, but otherwise no serious complication. Now, if we look at the breast tissue, which is most of the time unilateral, then we can see that this is the review from, this is the Kijay Chin's article about the anatomy. You will see that the anatomical innervation of breast tissue is so complicated. It gets nerves from neuroaxis, the spinal nerves, from brachial plexus, and from cervical plexus. And the same thing, Joanne makes a brief summary of breast tissue innervation, and it is a rather complicated innervation if you want to cover all aspects. Now, this is our study. We have performed ESPB. This is randomized study with control group, prospective study for breast surgery. And let's have a look at our conclusion. If you compare it to a control group, the total amount of opioid in Turkish population is 5 milligram if you perform ESPB for breast tissue in 24 hours. And this is, I would say, nothing. And if you don't perform a block, then the opioid consumption is much higher. Of course, the main issue, one of the main important questions that we have to answer, which block should we choose? Now that we have a large armamentarium of different regional anesthesia techniques, then we need comparative studies. Actually, we did this study. We compare ESPB versus thoracic paravertebral block, which is also one of our favorite blocks for, especially for thoracic area. And then what we found that ESPB and paravertebral block almost end up with almost equal analgesic consumption following surgery. So ESPB is quite similar to paravertebral, except that at postoperative first hour, paravertebral block group patients required less opioids, lower VAS scores, but otherwise they are almost identical. Now, there is a big question. What if we administer IV lidocaine, or if we inject lidocaine or any other local anesthetic just anywhere, but not at the level of the Erector Spinae plain block? Now, this time, Gözen Öksüz from Turkey has compared bilateral ESPB versus tumescent anesthesia done by the surgeons for postoperative analgesia in patients undergoing reduction mammoplasty. And what she found that ESPB is much, much superior to the tumescent analgesia, where you administer a huge amount of local anesthetic into the tissues. Now, this is a common interest area, I know, for Manoj, for me, and for Lönnqvist also, and the other colleagues that deal with regional anesthesia. Paravertebral blocks have been so famous for awake surgery or breast surgery without general anesthesia. But this is a case series, 100 patients from Australia. Let's see how they have done it. The patient received IV fentanyl, 100 microgram. The patient received propofol infusion plus local anesthetic infiltration by the surgeon. And this is what paravertebral block is probably most famous. And now this time 30 patients reported from India, ESPB erector spinal plane block for breast surgery without general anesthesia. They performed the block at T4 level. 25 milliliter of 0.5% bupivacaine was administered, plus dexamethasone. And then they administered fentanyl, 1 microgram per kilogram, plus propofol infusion. I tell you, this is nothing different than the paravertebral block with the earlier publication. So it means it's actually, if you remember the anatomy slide, the breast tissue innervation is very complex, and neither paravertebral nor ESPB alone, without additional local anesthetic or propofol infusion, would be enough for the surgical anesthesia. So it is nothing like axillary block or infraclavicular block performed for hand surgery. None of these patients would require additional analgesics or additional propofol infusion for surgical anesthesia. Now, this is a review actually for breast and thoracic surgery, 14 studies. Maybe it gives us a better idea. More than 1,000 patients have been included. And the conclusion is that ESPB reduces opioid consumption, reduces pain scores, reduces postoperative nausea and vomiting, and it is not clinically worse than thoracic paravertebral. So ESPB is quite similar to thoracic paravertebral block in conclusion of these 14 studies and more than 1,000 patients. And the recommendation is that ESPB is a viable alternative to thoracic paravertebral block. Now, cardiac surgery is actually not our topic today, but just very brief comment. This study from Philip Macaire, a well-known friend of us, a regional anesthesiologist, he published that ESPB and is good for cardiac surgery. I will not go into details. And similar results from children, pediatric cardiac surgery. And now let's go to the unilateral surgery, because this time today we are talking about unilateral surgery. And this is unilateral, kind of at least unilateral cardiac surgery. The surgical incision for mitral valve replacement is via mini thoracotomy. And they showed that ESPB was performed before induction of general anesthesia, 0.2 milliliter per kilogram, and 0.375% ropivacaine. And it is very effective for pain control. Mechanical ventilation times are shorter, and the time spent in ICU is shorter. So ESPB for mini thoracotomy cardiac patients is definitely clinically useful. Now, when it comes to rib fractures, this time 4 patients, the study also, the investigators also have a look at where the local anesthetic goes, but this has been already extensively discussed, so I will skip it. But anyway, it shows that ESPB is good for rib fractures. And my clinical experience also, I have performed ESPB for ICU patients with multiple rib fractures, and it definitely works, improves pain control, and the patients can take deep breaths. And this is the use of ESPB in the emergency room. In the emergency, it's not that easy to have anesthesiologists visiting every patient and intervening every pain patient. But this is a rather simple technique that even I think emergency physicians can perform. Of course, it can be a subject of another discussion, but the conclusion is that ESPB works for rib fractures. And this is a study for paravertebral for rib fractures, paravertebral, thoracic, epidurals, and serratus anterior plane block, they all work. And when it comes to ESPB, ESPB also works. If you do ESPB and favorably, if you place a catheter, And then you can do intermittent injections. And if you like, you can do a continuous infusion plus bolus doses. ESPB is definitely good for rib fracture patients, and it is technically simpler and easier. Now this is kind of a review and recommendations for rib fractures. And if you look at the anterior and lateral fractures, serratus anterior plain block has been recommended. For posterior and lateral fractures, ESPB is recommended, but of course you can do serratus anterior or paravertebral. And for bilateral fractures too, ESPB is one of the good alternatives. So simply for rib fracture patients, ESPB provides analgesia for unilateral or even bilateral fractures, trauma. It provides analgesia of the anterior and posterior hemothorax, and it can be performed in any position. It is technically easier because it's much superficial than the paravertebral or intercostal or epidural. It can be inserted even in the emergency department, and there will be less hemodynamic disturbance compared to the competitors, and lower risk of complications, especially in the anticoagulated patients. This is very important because we are in the era of anticoagulants, because many patients are using anticoagulants for different reasons. But if you think of the post-COVID era too, then we have another strong reason for the widespread use of anticoagulants. That's why ESPB is definitely an important alternative in regional anesthesia practice for thoracic analgesia. Now, of course, there are lots of critics too about ESPB, lots of publications besides lots of critics, like Linguist has done. Many people are skeptic because people think we do something simple, but it works. How come? They find it difficult to believe. And then the simplicity should not be a disadvantage. Actually, it's an advantage for the anesthesiologist, because if you think of paravertebral block, or if you think of the thoracic epidural, actually not all the anesthesiologists are willing to do these thoracic interventions. But on the other hand, thoracic ESPB is technically much simple block. There is no worries about coagulopathy. But if you think of thoracic epidural, then especially in this age of anticoagulants, of course, there are limitations. There are technical difficulties, and the experience is unfortunately a problem. If you are not doing it every day, you may not want to do it. And of course, no need to say that thoracic epidural has potential serious complications. And as it has been explained earlier, the failure rates are unfortunately high for thoracic epidural. This is a recent study. They performed the epidural in the preoperative holding area. It took around 20 minutes. And if you do it in the operating room with more stress from the surrounding, then it takes 26 minutes. And failure rate, it is 16% in the operating room, and in the preoperative area, it's around 5 to 6%. Now, this is unfortunately serious complications coming from the old days, 1998, intrathecal catheter placement or intrathecal drug administration with epidurals and paraplegia and permanent neurological injury, unfortunately. And it is a subject of discussion. It's a topic, how to prevent the nerve damage during central neuroaxial block. But we don't have such a discussion for ESPB. ESPB, as long as you do it correctly, you are not that close to the neuroaxial structure. So it is nothing that you can compare. And that's one of the reasons why people are using ESPB. This time, 2 case reports. The year is 2021 from this year and from Germany. Now, 1 epidural in the spinal cord itself and 1 epidural hematoma. So these are very serious complications. Of course, it doesn't happen every day, but it is a potential complication. What about paravertebral blocks? Paravertebral blocks are, of course, old, reliable blocks. We know the mechanism of action for sure. There's no discussion about it, but they are technically challenging,
especially if you skip ultrasound in part of an area where there is no ultrasound, then unfortunately the number of people performing paravertebral block is few. Actually, it is the ultrasound which has increased the performance of paravertebral blocks. Now more and more people can do it safely, but there are some potential complications we have to be aware. Of course, one is pneumothorax, because we are just above the pleura, so close, as we have seen in the Manoj movies. And sympathetic block, sometimes it is good, but sometimes we don't want this sympathetic block and the hemodynamic response to it. And the same thing with epidurals, of course. And unfortunately, a serious complication, total spinal anesthesia, can happen with paravertebral block too. And the risk of failure, unfortunately. This is total spinal block after thoracic paravertebral block, and in other cases, total spinal anesthesia following paravertebral. So this is a big complication in the hands of anesthesiologists. Of course, we can cover and manage, but still there are potential serious complications. Failure rates, especially if you skip ultrasound, if you forget about ultrasound, you do the paravertebral block and expect that it works. But we didn't really know the failure rates, or in other words, we didn't know the exact success rates. And in one of the previous lectures, it was said it was 28% the failure rate. I have just updated my slide. And total spinal anesthesia is a devastating complication. Pneumothorax may happen. Epidural or spinal spread may happen, but this time actually we don't consider it as a complication, and it's a mechanism, it's a way of mechanism of action, and some hypotension and bradycardia we may expect, of course. This is a very nice picture from Ki-Jae Chin, where he compares epidural anesthesia, paravertebral, and ESPB. And to be fair, as a regional anesthesiologist working in this field, we know that epidural anesthesia is much stronger. Then comes paravertebral, and then ESPB. And with these interfacial plane blocks, and also with ESPB, there is great variability of the clinical effect. And I tell you something, that the clinical effect does not always correlate with the anatomical studies always, because anatomical studies conflicting results, but in the clinic we say that ESPB works. So it is probable that the dye spread does not parallel to the clinical effect, what we see in real life scenarios. So I would like to greet all of our colleagues who are attending the meeting. This is a greeting from sunny Istanbul. Here you can see the bridge connecting Asia and Europe. But of course, we all have different views, and we may want to have a look at the same view with different eyes. And some may see the funny fisherman on the same screen. So maybe this is how we look at the blocks, ESPB, paravertebral, and epidural, and we all had to defend something different. But these are all included in our armamentarium, and we have to choose the correct technique. Thank you very much for listening to me. I will just make a brief summary. ESPB, from my eyes, is effective for thoracic pain, and we use ESPB almost routinely for great majority of our patients, thoracic, breast surgery, and so on. It is technically easy. It is not a disadvantage, but it is an advantage, so that many more anesthesiologists in the whole world can use it. Regional anesthesia is widespread used. It contributes. It is much safe, nothing comparable when it comes to safety to the competitors. There is no hemodynamic change, even if you do it bilaterally. And just a reminder, if you remember the picture with the ESPB, paravertebral, and epidural, ESPB should be considered as part of multimodal analgesia. So you should definitely give some systemic analgesics to have a superior analgesia. And thanks for listening to me.